and how to go to. So, good evening, everybody. Today we'll discuss about common OPD medications, and as you all know that medications in the pediatric cardiology OPD are very few, but we need to monitor them very closely, all the patients, because they may have side effects as well. So our presentation won't be very long because our list of drugs are small, especially OPD medicines. But let us brush up few important aspects about these medicines. So as it is a quiz, I will ask you the questions first. So can anyone tell me that do we need to do any investigations before starting Furosemide and Enalapril? If yes, what are they? Anybody? Nobody is typing. Please answer. Hello. Renal function and electrolytes from Dr. Ghosh. Dr. Ghosh, Sanjeevan Ghosh is very right. We should order renal function electrolytes, especially in newborns and infants, because they may have associated renal anomalies, they may have renal functional disorders, and these two medicines are notorious in patients with renal dysfunction. So it is must. Doctor from Bangladesh or Balangnesh has written that to rule out renal artery stenosis. Yes, but that is very rare. Actually, we want to know any renal dysfunction, in whether it is dehydration-induced renal dysfunction, because many of them have poor feeding habits and subclinical dehydration is very known. And if we give patients with renal dysfunction, if we give these two medicines, they may end up in serious trouble. And in our OPD, we have often seen that such patients may not show obvious signs of renal dysfunction, but when we do this test, then only we'll come to know about the problem. And there are instances wherein we have received the patient in very bad shape just because patient was on these two medicines without any prior renal function evaluation. So it is must. In fact, we may avoid it in a grown-up children like those who are more than 5 years, but still it is ideal to do, as many of you have told me that the right answer, that we should monitor renal function test and electrolytes. We should do it baseline. And in fact, I would add one more test. Anybody? Renal function test, electrolytes, any other test? Somebody has written uric acid, no. We should do USG abdomen also to rule out any congenital renal anomaly. So USG abdomen, renal function test, urea create, and electrolytes are mandatory. And when these tests are normal and we are starting these two medicines, we should periodically monitor. In infants, little more often, maybe every 2 to 3 months. And in grown-up children, at least once in a 6 months, we should monitor renal function test and electrolytes. So furosemide, as you all know, it's a common medicine, and we'll touch upon first. Can you tell me what is the mechanism of action of furosemide? The loop diuretic. What does it do? What is the exact channel on which it works? So nobody. Blocks sodium potassium channel in a loop of Henle. Fine. So with this action by Dr. Amitosh Singh is a right, he has given the right answer. So this causes the diuresis. And what is the side effect? What are the side effects of furosemide? Please type fast, because this is a quiz, so that's why I'm waiting for your response. Otherwise, if this would have been lecture, I would have, delivered the lecture. So hyponatremia, hypokalemia, hypotension. Okay, so basically dyselectrolytemia. Anything related to calcium? Anybody? It causes calciuria, right? Correct. And what else related to calcium? What can be seen in USG of kidneys in terms of calcium? It causes nephrocalcinosis. Okay. And regarding hearing, anything regarding hearing? Yes, it causes ototoxicity. So whenever you are asked question, better to write, side effects together, or better to verbalize side effects together rather than one by one waiting for examiner. I'm just preparing you guys for Viva, because when you tell one side effect, examiner will tell you, okay, what is next? Then you will tell second side effect. Then he will tell you what is next. So it may be disturbing to them. So better to tell at a stretch. And as you all know that we have to monitor this renal functions, especially when baby is on furosemide and enalapril. So what is the dose of enalapril? Right. So 0.1 to 0.6, even we can go up to 1 mg per kg per day, but that's too high. Generally, we do not go up to that. So we generally start with 0.1 mg per kg per dose in 2 divided dosages. What is the mechanism of action? So how does it help in patients with large shunt? AC inhibitor, we all know that. Anybody? So AC inhibitor is the right answer, mechanism of action, but how does it help to patients with large shunt? Okay, you read it. Okay, I am keeping it for you for homework. So what are the current indications of digoxin in OPD? Fast, anybody? A very common drug. All of you must have written this in the OPD. Heart failure, symptomatic benefit. Dr. Ghosh, digoxin doesn't have proven role in a patients with large shunt related heart failure. So most of us do not write digoxin in this condition. Which is the most common indication for which we give digoxin? Heart failure because of what? In cases of myocarditis, dilated cardiomyopathy, we give digoxin. It has a proven role in a structurally normal heart. In patients with tachyarrhythmia, especially SVT, we do give digoxin. About patients with large shunt related heart failure, most of the cases furosemide and enalapril suffice. Digoxin doesn't have any proven role. But rarely, if patient is not responding to these two medicines, we can try digoxin. But remember, theoretically, it doesn't have any proven role, and nowadays we hardly write this medicine for large shunt related heart failure. When to adjust the dose of digoxin? Okay, anyway, what is the dose of digoxin? Dr. Amitos says 5 microgram per kilogram. What, per day, per dose? It's incomplete answer. It's a 10 microgram per kilogram per day. Okay. When do we give BD? When do we give OD? Dr. Ghosh, we are talking about OPD, and generally we do not load patients. We straight away start maintenance. So my question was whether we give this medicine OD or BD. Dr. Amitos has written BD. When BD? And can we give it OD? So remember, children less than 2 years of age, we should be giving it BD, and children with more than 2 years of age, we should be giving it OD. Okay. Is there any role of 5 days a week? Anybody 5 days a week? Do we prescribe it? When? Why? Okay. So let me answer. Traditionally, people have prescribed it for 5/7, but we have seen that the effect of digoxin is better when we give it daily, continuously, without any gap. Okay, this especially those children or those parents, if you feel that compliance to follow-ups may not be that optimal, in that case, just to be on safe side, you can give it 5/7. But suppose for my patients, rarely, probably one patient in a year or so, I give it 5/7. Otherwise, I prescribe it in a daily dosages. And what are the side effects of digoxin? The commonest side effect. Nobody is typing. Commonest is vomiting, right? arrhythmia, any form of arrhythmia are known. What is the first side effect or first effect of digoxin toxicity on ECG? First sign of digoxin toxicity on ECG. Anybody? Nobody. So it's homework. Find out what are the abnormalities in ECG seen in patients with so Rajesh Kumar is right. Here interval prolongation is the first effect. And what about when do we adjust the dose? When do we adjust the dose of digoxin? I mean to say that when do we reduce the dose of digoxin? Usual dose we have discussed, 10 microgram per kilogram per day. But when do we reduce the dose? In patients with prematurity, we reduce the dose of digoxin to 5 to 7 microgram per kg per day. Patients with renal failure also we reduce the dose. Or sometimes if renal dysfunction is severe, we have to withhold the digoxin. Any drug-to-drug interaction, especially when patient is on Amiodarone, we have to reduce the dose. So, because both of them are arrhythmogenic agents. So, what is the mechanism of action of spironolactone? Nobody? Aldosterone antagonist. Okay. What is the action on potassium? What happens to potassium when patient is taking spironolactone? Potassium sparing diuretic. And apart from this effect, is there any additional effect of spironolactone on the heart or anybody? Yes, Dr. Sanjeevan Ghosh is the right person. Remodeling of myocardium, especially ventricular myocardium. And that's why it is very commonly used or always used in patients with dilated cardiomyopathy. So, Lasilactone contains two medicines. We all know what are the dosages of both. What are the content? 20 by 50. What is 20? What is 50? Whether it is milligram, gram, we should write properly, Dr. Ghosh. Whenever we answer, we should answer appropriately. What is 20? What is 50? Very good. Excellent. Have you heard of minilactone? Have you heard of minilactone? Nobody. So this is your homework question. Please find out. Basically, it is a combination of furosemide and spironolactone, but the dosages, individual dosages are less, content is less. So please find out. It will be helpful for in smaller children. When do we give iron in our OPD? And why? Fine. What about acyanotic congenital heart disease? My dear friends, I want to emphasize that majority of our Indian children are iron deficient, and especially those with chronic congenital heart diseases because of various reasons, nutritional issues, things like that. So ideally, we should give iron to almost all children with congenital heart disease, even those with dilated cardiomyopathy, because we want to increase their oxygen carrying capacity. And majority of them are anemic. Most of them are anemic by lab parameters, and remaining of them are anemic even clinically also, and they have anemia related issues. So it is good idea to give iron in all patients with congenital heart disease, especially hemodynamically significant lesions. I am not talking about a healthy baby with a small VSD, but any baby which requires some medicines like Furosemide or Enalapril or Propanolol. So all patients with cyanotic CHD, it is must, and it is in acyanotic CHD, those with hemodynamically significant lesion. What is the dose of iron? So very easy. So 3 to 6 milligram per kilogram per day. In fact, lowest is even 1 milligram per kilogram per day. And we usually give around 3 milligram per kilogram per day, but depends on hemogram. We can adjust it, and whenever required, we can increase it. What are the common side effects of iron? Anybody? GIT side effects? Children won't have this issue of altered taste, but yes, it has a GIT side effects like black stools, nausea, vomiting, constipation. Even it can cause diarrhea. Nobody has mentioned about diarrhea. It can cause constipation. Constipation is commoner, but even diarrhea is not. How do you deal with this problem, especially GIT issues? Suppose mom tells that patient is having constipation after starting iron. So what do you do? So it's a practical question, right? Nobody is answering. So we have to reduce the dose of iron of a same brand. Suppose we are writing tonoferol, so we have to reduce the dose and see. If that is also, majority of the cases it works. But if it doesn't work, you change the brand. Like if you have written tonoferol, you may switch over to Orofer XT or Ferrifol XT or something like that and try. Majority of the children's GIT issues are solved with these two steps. Rarely we may have to require to stop iron, but it's very rare. Majority of them respond to reduction of the dose, and remaining ones respond to change in the brand. especially grown-up children, which particular single advice will you give if a patient is receiving iron? Anything related to teeth? We all know teeth staining. Dr. Amitos, Dr. Rajesh Kumar, we all know that there is a teeth discoloration. But what do we advise then? See, these are the practical aspects. You should know how to deal with this. Any grown-up child, if he or she is receiving iron, we have to tell them to brush teeth twice a day. Rinse the mouth is fine, but brushing the teeth at least twice a day is very important. And it is good idea to, do brushing after receiving iron in the morning as well as in the night. So what is the dose of propanolol? Very common medicine. You have got 5 to 2 mg per kg per dose. See, we can give it BD, we can give it TDS, even we can give it OD. So that's fine. Usually we give it BD. What is the maximum dose of propanolol? Per day I want. Mg per kg per day. Maximum dose. Nobody. 6 milligram per kilogram per day we can go. But rarely. We have to closely monitor the heart rate. And in patients with, what is the indication of propanolol in pediatrics? Especially pediatric cardiology. Very good. Dr. Ghosh. Cyanotic spell, arrhythmia and hemangioma. But let me tell you that a child with tetralogy of Fallot, even if child doesn't have a spell, we have to give. So any patients with TOF, only TOF, my dear friends, TOF and TOF like physiology. So TOF and TOF like physiologies. What are the TOF like physiologies? Anybody? DRA VSDPS, TGA VSDPS, single ventricle VSDPS, corrected TGA VSDPS, right? So all these patients, even if they don't have spell, we have to give propanolol. And why do we give propanolol then? Severe mitral stenosis, we can give propanolol, right? So in patients with cyanotic CHD with reduced pulmonary blood flow, like TOF and TOF-like physiology, we should be giving propanolol. What is the reason? Why do we give propanolol in these children? And what is the mechanism of action? Infundibulum muscle spasm by inhibiting sympathetic activity, it's okay, but even prior, what is the most common mechanism of action, and that is the reason? It stabilizes the PVR. It stabilizes the SVR PVR balance. Please remember this. And thus, it prevents cyanotic spells. I am writing it also so that you can note it down. Because it prevents cyanotic spells. So it stabilizes the SVR PVR balance, and thereby it prevents cyanotic spells. So a patient with pink top, should we give propanolol? Yes or no? Pink top, anybody? We must give propanolol and iron in a patient with pink top as well, because any patient with top or top-like physiology, they are vulnerable to cyanotic spells, and we want to prevent this. So Carvedilol, when do we give this? Dilated cardiomyopathy. Mechanism of action? Okay, it reduces the heart rate, let me tell you. Then alpha beta blocker. It reduces the heart rate, and thereby how does it help the patient with DCM? Ventricular remodeling is another effect, but the commoner is that by reduction of heart rate, it improves the diastolic time of cardiac cycle, and thereby by reducing it increases the diastolic phase of cardiac cycle, and by increasing time duration of diastolic phase of cardiac cycle, it improves the ventricular filling, and thereby it improves the cardiac output. So this is the answer. What is the dose of Carvedilol? mg, yes, right. Dr. Ghosh is right. 0.1 to 1 mg per kg per day. What is the commonest brand easily available? Carvedilol. Cardiovas, right. Okay, before, what are the indications of Amiodarone? OPD. We all know it's tachyarrhythmia, mainly SVT. Ideally, what are the tests to be done before starting Amiodarone? Bus, only thyroid. Anything else? Yes, Dr. Sanjeevan Ghosh is right. Thyroid function, liver function, and CBC. What is the loading protocol of oral Amiodarone? What is the maintenance? Oral loading we are talking, because this lecture is all about OPD medicines. So 4 milligram per kilogram per dose TDS for 1 week, then BD for 1 week, and then OD for 1 week. Correct. So this is how we should load it. and then maintenance 4 milligram per kilogram per dose OD. So last two slides only. Case scenarios: a newborn with large perimembranous VSD measuring 8 mm, left to right shunt. Patient is completely asymptomatic, 4-day-old newborn baby. What will you give to this baby? Anybody? Nothing. Dr. Sudipta, Dr. Amitos both have given the right answer. Even Dr. Ghosh. So at present nothing, but we need to follow and to see what are the effects later on, especially at 6 weeks of age when there is polyneonatal PVR, they may develop symptoms. A newborn with cough, 4-day-old baby, newborn saturating 92%, stable, patient having diagnosis of tetralogy of Fallot. What will you give? Dr. Ghosh, Dr. Sudipta, Bhattacharya, anybody? PA anatomy, PS. Dr. Ghosh, it is tetralogy of Fallot, and we all know. PA anatomy may be different, branch pulmonary artery, PS, but it's tough. Patient is stable. Situation I have told you. So no drugs. Dr. Amitos Singh has told us there's no drugs. So what else? When do we give drugs? Remember, a patient newborn at 1 week of age, we can start iron. Iron at 1 week. We should start. And propanolol when? At 1 month. Why 1 month? 1 month is the right answer, 4 weeks. Because stabilization of sympathetic nervous system happens by around 4 weeks of age, so we should start. So remember, any patient with any newborn with tetralogy of Fallot, start iron by 7th day of life and then add propanolol at 1 month. Monitor heart rate and keep on increasing dose of propanolol and iron as weight increases. And many times it is seen that those babies who are on regular follow-ups, regular iron and propanolol, they remain in a better tough category. They have minimal symptoms. Many of times they are pink tetralogy, and then majority of them have absence of spells. Though it is not a guarantee, but if we give these medicines pretty regularly, and if we keep on increasing the dose as age advances, it really benefits the patient. Okay, patient with large PhD and coarctation. Symptomatic infant. What do we give? Large 7 mm perimembranous VSD, severe coarctation of aorta. Dr. Mirza, we don't give Enalapril to these children because there is a coarctation of aorta. We are not talking about surgery, Dr. Ghosh. We are talking about medicine. So we should give Furosemide only, and that too lower dose, around 0.5 to 1 mg per kg per day, because they are fragile kids, and Enalapril causes afterward reduction, and it can harm the patient. So we must not give Enalapril. We should give low dose Furosemide only. So in summary, every patient is different in OPD, and treatment must always be individualized, depend on the child, clinical scenario, and hemodynamics and the lesion. And ongoing monitoring is must in these children, especially renal function, kidney. Many times what happens that a patient with truncus arteriosus, patient is on Furoped, Enalapril and iron. Now patient is at home waiting for surgery. Patient's symptoms deteriorate and they have significant feed refusal. So parents, they know that this is a heart medicine, so they will never stop Furoped and Enalapril. But here patient is not receiving feeds adequately. So what will happen? There will be dehydration and pre-renal failure. And because of ongoing Furoped and Enalapril, it can be converted into renal dysfunction. And we have seen many such cases where they have very, very bad renal dysfunction and they are in bad shape, and we have to really struggle hard to make sure that kidney is normalized. So it's very important to monitor renal function and ongoing monitoring, and also advise them that whenever there is a diarrhea, vomiting or feed refusal, they should withhold the Furoped and Enalapril and they should contact the treating doctor. So these are important, simple measurements, simple measures which helps to treat patients optimally, and as a clinician we have to give them advice whenever we are writing this medicine. We have to make them aware about all these things which we have discussed. So thank you all for attending the lecture, and